Is it visible in full screen, I hope?
Yes, yes. Yeah.
Excellent. Okay. So I've tried to keep the topic general and to the point, but I would encourage all of you to post your questions as and when you feel, and so that we can address all of them at the end. Fine. So our topic for today is antimicrobial stewardship in NICU. So we will be covering the topics. So we will be covering the topic in four main headings. One is antimicrobial resistance, which is very important to understand before we understand the even seek to understand the importance of antimicrobial stewardship. Then we'll understand what is antimicrobial stewardship and what are the core elements of the program, how do we implement it, and most importantly for this session is what is the nurse's role in antimicrobial stewardship. So coming to antimicrobial resistance, I'm sure that most of you would know by now what it is. But just to reiterate, antimicrobial resistance is said to occur when the microbes, which could include bacteria, fungi, viruses, parasites, but most importantly bacteria in our setting, they change with time and they stop responding to the antimicrobials that were previously effective against them. So all of us have heard terms like MRSA, which is methicillin-resistant Staphylococcus aureus, or more commonly for a common audience, we could see that MDR-TB is often we hear that drug-resistant TB is increasing. So all of these are examples of antimicrobial resistance. And the main cause of antimicrobial resistance is the misuse and overuse of antibiotics. We'll see how that is responsible for it. So, but now that the microbes would not respond to common antimicrobials that they were previously sensitive to, the infections become longer, they are difficult to treat, they're more severe, and they obviously become costlier also because you have to use longer antibiotics and costlier antibiotics. And it leads to more hospital stays, more complications, and more deaths. So antimicrobial resistance has become a major public health issue. So to reiterate, from a NICU perspective, roughly around 1 lakh neonatal deaths occur each year, 1 to 1.5 lakh, in fact, in India alone from neonatal sepsis. And now it is thought that more than 30% of it is attributable to antimicrobial resistance. What this means is that if the microbe resistance were not there, many of these sepsis cases could have been preventable. And for the first line antibiotics that we traditionally used, which is ampicillin, gentamicin, as recommended, 50 to 88% of isolates, bacterial isolates, are now resistant to it. Just to show some basic idea, you don't have to go to the detail of this graph, but this is from a study that was led by Professor Jiva Shankar, in fact. So we did this in district hospital study. So our traditional understanding is that the more severe NICU, the more acute NICU that you see, for example, in NICUs, the resistance would be higher. But we saw that even in district hospitals, if you notice here, the light blue one is the multi-drug resistance. So for example, around 84% of Klebsiella species were multi-drug resistant already in district hospitals. 84% of E. coli, 88% of Enterobacter, 75% of Acinetobacter have become resistant to many antibiotic classes. So to understand how this resistance develops, what happens is that first of all, there is normal mutations that keep happening in the genome of a bacteria. And what happens if suppose there's many bacteria, some would have some mutations or some would be resistant to an antibiotic. Now, when we give antibiotics, which typically are not uh, in proper dose or in proper duration, then what happens is that some of the bacteria get killed, the ones that are clearly susceptible. But the ones who have some resistance genes would keep on persisting despite the antibiotics. And then over time, the resistant ones keep on growing, and gradually you would see that the whole microbial flora becomes a resistant sort of a flora. And then like the bacteria can also transfer their property of antimicrobial resistance to different bacteria. And this is where the main problem lies, that not only a bacteria can become multi-drug resistant, it can also transfer its multi-drug resistance to other bacteria so that it keeps on spreading. Now, how does it spread? Suppose how I explained, the patient has received antibiotics, and then suppose this resulted in drug-resistant bacteria, as we saw in the previous photograph. So the patient attends the clinic, and then from this patient, through some hands, through body fluids, through surfaces, it would spread to other patients, and that is how it keeps on spreading. It initially spreads like contamination, and then it can cause infections also. Another major source of antimicrobial resistance today is felt to be from veterinary practice, in which often antibiotics are overused and without much regulation for animals to prevent infections in them and to increase production. And these animals also lead to just the development of drug-resistant bacteria, and which then reach through us through food or through contact with animals through environment. And this is how it keeps on propagating. So again, so if you see this color, we don't need to go into the details, but with every passing decade, the above line shows a decade, there has been reported resistance to various antibiotic groups. Almost all antibiotic groups that we have heard of have now reported to have some resistance. The common one is MRSA, as we discussed. There's vancomycin resistant enterococcus. There's resistance to ceftriaxone, polymyxins, linezolid. On the flip side, the above photo shows how the newer antibiotics have been developing over time. So as we see here, 1950 to 1960. So the first, often the clinically available antibiotic that we read is said to be penicillin, for example, in 1920s. And then in 1950s to 1960s, we developed a lot of antibiotic classes, including, so most of the things that we use, quinolones, vancomycin, aminoglycosides. So this example is amikacin, tetracycline, macrolide, were developed in this period. And then in the last 50 years or so, very few newer antibiotics are being discovered. And even the ones that are being discovered have now started to show resistance. So this is like getting stuck between a rock and a hard place. On one side, we see that more and more antibiotics are developing resistance to their effective action. On the other hand, the newer antibiotics are not being discovered enough, and it is very difficult and very costly to find new antibiotic classes to which resistance is not there. So both these two things result in a double jeopardy here, in which the antimicrobial resistance, although it is not a disease per se, but it is indirectly and directly causing a lot of deaths, and it has become a silent epidemic. So for example, in 2019 alone, around 5 million deaths occurred because of antimicrobial resistance alone. This is only third to ischemic heart disease and stroke. So much more than cancer, more than neonatal conditions. Antimicrobial resistance is now ranked third. And because, as we saw, that antimicrobial resistance is only likely to increase because the bacteria can spread their genes of antimicrobial resistance, and because there is a selection pressure in which the resistant organisms are selectively saved, this is likely to increase. So for example, by one projection, by 2050, around 10 million deaths per year could be occurring due to antimicrobial resistance. And this is a huge, huge number, and we have to do something about it. So because of this, WHO as well as the government of India has taken it into a priority area in which we have to tackle the epidemic of antimicrobial resistance. And it is one of the top global public health threats right now. So coming to what we can do about it. So this is what caused antimicrobial resistance, as we discussed. Overprescribing of antibiotics, patients not finishing their treatment, overuse of antibiotics in livestock, lack of new antibiotics, lack of hygiene and poor sanitation, which causes the spread, and poor infection control. Now, in this, the lack of new antibiotics is barely in our hand. It is difficult to do, and as medical clinicians or nurses, we cannot be developing new antibiotics. Again, livestock and antibiotic use is under the radar of the government. They are trying to work on it, but it is very difficult to do, and it is not as regulated as human practice, for example. So the things that are left for us to work on is one, that we can reduce or make a judicial use of antibiotics, prevent over prescribing, and ensure that patients finish their treatment. The second one is to prevent the spread of infection and infection control and proper sanitation and hygiene things. So these two things are the major areas to focus on. And these two things are what we call as IPC, infection prevention and control, which is the latter, the lower, the two things that we can act on, and antimicrobial stewardship, which means preventing antibiotic selection pressure and optimizing the use. So our today's session will focus on the antimicrobial stewardship part, and I'm sure that IPC has been covered previously also, and it would be covered in other sessions. So for example, the housekeeping session that you had was part of infection prevention and control. So now that we have understood why the problem of antimicrobial resistance, we need to understand that what is antimicrobial stewardship. Fine. So now let us first understand, what does stewardship mean? So stewardship means the careful and responsible management of something that is entrusted to one's care. So there's an inherent and implicit sense of accountability and ethical intent. So it means somebody who's a custodian of a responsibility, and we have to do it properly. So this is Sir Alexander Fleming. And he said that even in 1945, he predicted that a time may come when penicillin can be bought by anyone in the shops. And it is what happens in India, as we know that antibiotics are easily available over the counter often, although it may not be recommended, may not be legalized, but it is still sold everywhere. And that now there's a danger that any ignorant man can easily underdose himself and exposing his microbes to non-lethal quantities, making the drug resistant. So we have to understand that the resource that Dr. Fleming mentioned and what stewardship here entails is that antibiotics are a shared resource that we are entrusted with. And indeed, antibiotics have been one of the miracle discoveries of the last century, and it has saved millions and millions of lives. But it is in thin ice right now, and it is losing its importance. So antimicrobial stewardship now is, the definition is presented here. So first of all, take note of all the colors that I have highlighted. First, it is a systematic and multidisciplinary health strategy. So it cannot be done by one person, by one or by one specialty. It has to be multidisciplinary. Much team is involved, as we'll discuss. It is designed to optimize antibiotic selection, dosage, and duration. So optimize means that you have to give it to the right person. It does not mean that you have to use less and less. If it is indicated, we still have to use it. To improve patient outcomes and minimize harms. So it means that not we are trying to improve the patient outcomes, but only amongst those who rightly are indicated to receive antibiotics. And antimicrobial stewardship also includes trying to reduce harms. So for example, if the harm is anticipated, for example, there may be renal toxicity with amic acid, so you will be careful by giving it in a patient with renal toxicity or renal failure. And same way, some patients may have allergy to a drug. So you have to minimize the harms. And the ultimate goal is to combat antimicrobial resistance, which is the main problem right now. So in simple terms, what antimicrobial stewardship means, and people have said, is that it is giving the right antibiotic to the right patient at the right time and right dose by the right route and for the right duration. So this is, again, easier said than done, but this is what the principle is, that you have to optimize the use of antibiotics. So as I said, antimicrobial stewardship is not about not using microbials. It means to identify the select group of patients who really need antibiotic treatment, and then explain, reassure, and educate the large group of patients who don't. Because it is the tendency that when in doubt, people tend to prescribe antibiotics. But we have to educate and explain the situation to the patients that do not require antibiotics also. And as I said during IPC, that the best way to reduce antimicrobial resistance is to reduce microbes. So basically, the best way to reduce antibiotic use is to prevent infections. So IPC is part and parcel of a successful AMR program. And if the IPC practices are not in place, then AMR or antimicrobial stewardship programs cannot be successful. So as this is the concept of antimicrobial stewardship that we just discussed. Now let us discuss what are the core elements of the program. So as we read the first sentence for the definition of antimicrobial stewardship, it was that it is a systematic and multidisciplinary health strategy. So it cannot be done in isolation, and it cannot be done by one motivated person alone. It needs a team of people, and it has certain core elements. So these elements include, one is leadership commitment. We'll discuss these one by one, that what it means. There has to be accountability fixed and the responsibilities assigned. Then there would be specific technical aspects of antimicrobial stewardship principles that we'll focus this discussion on. There has to be reporting and feedback, that whatever uh, uh, progress we are seeing with the results, we have to communicate it to the team so they can do better. There has to be monitoring and surveillance, which is measurable so that you can see the impact. And there has to be an ongoing prospective as well as retrospective, as in you first educate initially also, and then once you see the progress and with the feedback, you again reiterate the principles. So education and training is an ongoing part. So for example, the class that we are taking right now is an example of education on antimicrobial stewardship, which is the first aspect, but it does not end there. It has to be ongoing. So in team approach, there is typically a team of individuals that would constitute a good antimicrobial stewardship program at a hospital or in a unit or in a department. So typically it would involve that the healthcare facility leadership has to be involved. So for example, this could mean the uh, registrar of the institute, the director of the institute, or the head of the microbiology department, but somebody who has power, who has accountability, and who has the leadership to implement this and ensure that people follow the principles. So this can include heads of departments, for example. They constitute an antimicrobial stewardship committee, which could work hand in hand with the infection prevention control committee or patient safety committee. So in the AMS teams, who all will be there? There would obviously be the clinicians, the doctors, the nurses of the unit. There would be some special dedicated infection control nurses or the antimicrobial stewardship champion nurses. There should preferably be a microbiologist who would give technical guidance on the antimicrobial growth and which agents would be suitable. Preferably, there should be a pharmacist or pharmaceutical expertise who can guide on the antibiotic, the proper doses, durations, and the medical practitioners or the surgeons, as I discussed. So this whole thing has to have accountability, and that is why we need a dedicated team. Again, so just saying that the whole team or the whole department is acting for antimicrobial stewardship is not enough, because if there is no person to dedicate it to clearly, then there is no accountability. I'm sorry, I saw heard some noise. Is there a question? Should I go ahead?
I think so. Somebody must have accidentally.
Yeah,
Yeah,
yes.
okay. Sure. So the leadership commitment requires not just investment of time, energy, but also resources. And the leadership has to have the powers for organization, for effectively communicating the messages, and for critical analysis of the processes and the outcomes. So, as we discussed, the crux of antimicrobial stewardship is on the judicial use of antibiotics, and which means the right drug, right dose, right patient, right duration. So the most important aspect to prevent antimicrobial resistance is the right drug to be used. And we have to understand that in broad settings, we say that every fever is not due to bacterial infection. For neonates who often don't mount with fever, we could say that every sickness is not due to bacterial infection. So any sick baby is coming does not mean that you have to start antibiotics. And there has to be specific pointers to the presence of infection and bacterial infection to start antibacterial agents. The right antibiotics, even in suspected bacterial cases, would depend on the patient, the clinical presentation, the likely site, the care setting, and the patient comorbidities. And we'll come to how to decide this antibiotics. Then you have to always check the antibiotic dose before charting and administering, and you cannot rely on memory alone for this. So now to have a standard, just because the whole point of having a program is to have a written and a well-defined protocol, so that not only people can follow it, but somebody can track that how is the outcome based on following a standard protocol. If everybody follows a different protocol based on their understanding, then it becomes very difficult for somebody to audit or review how the whole system is working. So we need to have standard treatment guidelines, which are provided by typically larger bodies like NNF, for example, and we need preferably should have a unit specific protocol for antibiotics, which would mean not just the antibiotic type, but also when to suspect sepsis, when to send a sample, for example, and when to start antibiotics. So when we think of deciding a unit antibiotic policy, it should be based on the unit specific data for the bacteria. So what you need is a unit antibiogram. Now, what it is, I'll show a photo as well, is that it is the cumulative analysis, that it is a sum total of all the positive cultures that are coming from one hospital or from one unit, whichever this policy is for. In that, all the organisms are listed against the antibiotic susceptibility pattern of the organisms. And it excludes the surveillance culture. So it is only the clinical cultures, and you can have different antibiograms for different types of samples and different specialities. So for example, if you see here, this is an example of antibiogram from AIMS. As you see here, they've written ICU and blood. So this is for all the blood culture positive reports that have come from the ICUs at AIMS. So as for example, we see here one organism, Acinetobacter GNB, and we see that there were 97 isolates, and in the colors they have shown what percentage of the isolates were sensitive to the organism, to this antibiotic. So for example, we see Acinetobacter is only 6% cases were sensitive to ceftazidime, 4% was sensitive to cefepime. I hope this figure is visible enough in your screens. And we see 92% are sensitive to colistin. So same way, you need to know that in your unit or in your hospital, and for this sample, what proportion of the bacteria are likely to respond to a given set of antibiotics, and only then can you decide the empirical antibiotics. So what is the empirical antibiotics? So first of all, when we suspect sepsis and send blood cultures, we do not have the report of the blood culture. Obviously, it takes some 48 hours, 72 hours to get. So you have to start some antibiotics, but that cannot be any antibiotics. So you have to have a evidence-based decision on, for my unit, which is the first antibiotics I should use. So the principle would be that you would use the lowest possible category of antibiotics, which would be killing most of the bacteria, as we will discuss. So before we discuss how somebody would decide what is the first line and what is the second line antibiotics, you need to understand this classification. So the WHO has made a classification of the antibiotics, which helps us decide that which antibiotics should be used first, which should be used later, and which should be reserved for very severe or exceptional cases only. So this stands for AWARE classification, which stands for access, watch, and reserve. So access are typically the first or second choice treatment options and has low resistance potential. They may have a lot of resistance in so for example, like they have given an example of amoxicillin and nitrofurantoin. For neonates, what is often used, for example, amikacin, ampicillin, are access group. Then there is watch group of antibiotics. So these are the next second tier, in which they're critically important and there's a higher potential of resistance. So for example, cefotaxime, piperacillin, tazobactam, meropenem, vancomycin, these are all watch group of antibiotics. And then there are reserve antibiotics. So these are the last resort options, because this is like our final armamentarium drug, that we cannot afford that more and more antibiotic organisms become resistant to the reserve group. So this includes the high-end antibiotics like ceftazidime, avibactam, colistin, linezolid, and these antibiotics are also much more costlier and are the last resort options. So Now coming back to our discussion. So how to frame a unit antibiotic policy? So first of all, it should be written, explicitly available, and regularly updated antibiotic policy. And it should typically be based on the antibiogram of the unit or the hospital for the last 6 to 12 months. So you have sufficient number of bacteria on which we can base our decision on. Typically, it is said that at least 30 bacteria should have grown, but it may not be valid for all bacteria, but at least the common bacteria, you should have at least ideally a data of annual antibiogram, which is often what we do. So for example, in our unit, we have an annual sepsis statistics discussion for the preceding 1 year. And then based on that antibiogram, we would decide the empiric antibiotics for the next year. So it is it would guide the empirical antibiotic choices only, that which antibiotics to start with. And this would hold true until you have a culture result. And once you have a culture result, then you would obviously change modify your antibiotics based on what the organism has grown. So how do you decide the first line antibiotics for the unit? It is a combination of antibiotics which could cover 60 to 70% of all isolates. So for example, 100 organisms have grown in the last 1 year of varying types. Some could be Klebsiella, some could be Acinetobacter, some could be Staph aureus. And the combination of antibiotics, which could kill 60 to 70% of the 100 cases, would typically be my first line antibiotics. So, for example, the first line antibiotics that is recommended globally is ampicillin, gentamicin. But as we saw in the first few slides, that in India, around 50 to 88% are already resistant to ampicillin, gentamicin. Then the other options could be cefotaxime, amikacin, or piperacillin, tazobactam, amikacin. So for example, at AIMS right now, for our babies, piperacillin, tazobactam, amikacin is our first choice of antibiotics. But again, just because it is AIMS protocol does not mean it will hold true for some other hospital. So ideally, every hospital or close group of hospitals should, if possible, should develop their own antibiotic policy, which is suitable to their settings. Then we have a second line antibiotics which cover 80 to 90% of isolates. So the example could be you could upgrade to cefoperazone sulbactam, which is Magnex, meropenem, or vancomycin. And then there are reserve drugs which are similar to the WHO reserve that we saw. They would likely cover 90 to 100% of cases, but it should be avoided for empirical use and should preferably only be reserved for cases when the organism has grown, which is not sensitive to first and second line antibiotics. So the examples include colistin, ceftazidime, avibactam, or astrolin. So this is an example of the antibiotic policy for AIMS. So it is available as a mobile app, for example. So this is how the screen looks like. Once you click on it, it shows the different types of infections. So for example, as a neonatologist, I'm interested in these ones: asymptomatic neonates, or neonate with symptomatic sepsis, neonate with bacterial sepsis. And once we click on this, then I can select inborn baby, outborn baby. So outborn baby, the first line antibiotics is cefotaxime, amikacin, for example. So this is what I would use. Unless there is, once the growth, the culture comes and there's a growth of an organism, then I'll modify my antibiotics accordingly. But my empirical choices should be based on the antibiotic policy. And same way, there could be antibiotic policy for different hospitals, and not just antibiotic policy, but just the overall guidance on when to suspect, what cultures to send, what investigations to send. You would have various practice guidelines. They could be provided by WHO, they could be provided by the CDC in America, they could be provided by the NNF Forum India. So for example, the NNF India has provided a clinical practice guidelines on the diagnosis and management of neonatal sepsis. So based on how much the sufficiency of the hospital or the unit is concerned, you should try to have as individualized an antibiotic policy as possible. Now, what is the right duration of antibiotics? So the duration is fairly well defined as per our protocol, what we would do is that for any meningitis cases, we would give antibiotics for 21 days. For blood culture positive but no meningitis, it is 14 days. For culture negative sepsis, so the culture has not grown but the baby behaved like a case of sepsis, we would give for 5 to 7 days. For urinary tract infections, we would give for 7 to 14 days, and so on. So we need to know what is the duration. And the antibiotic should not go on indefinitely till somebody decides to stop it. As soon as we have a diagnosis, we have a culture report, we should commit that this is the duration of antibiotics that I am going to do. And then the right dose, as we discussed previously also, that we always need to check the dose of antibiotics before charting and administering. And ideally, it should be a 2-level sort of check. So the doctor who is charting the drug and the nurse who's preparing and administering should both be aware that this is the proper dose. And a good idea would be to suppose paste a list of the common drugs that you and the common antibiotics, what is the administration, how to prepare, how to dilute it, what is the typical dose. And if that is available at the bedside or like at the place where the nurses would prepare the drugs, that would always better than relying on memory. So we do, with time, we tend to remember the doses, but for neonates, often the case is that the duration, the dose of the antibiotics as well as the dosage frequency would vary with the gestation. So a 27-weeker and a 36-weeker may require a different dose of the drug, even if their weights are same. And it would vary with the postnatal age. It could be different doses in neonates who are not passing urine, who have renal failure, or who are on dialysis. And the dosing weight could be different in babies who are clearly edematous. So for example, a baby with hydrops fetalis, the weight would be higher because there's a lot of water, but the dose of the drug could be based on the dry weight of the baby. So all of these factors have to be considered, and determining the dose in especially neonatal cases is very important, and it should always be checked rather than written from memory alone. So this brings us back to we have discussed the core crux of the principles of antimicrobial stewardship. So what is the program and what is the antibiotic policy, in the sense that how to determine the right drug, right dose. We'll not go into the specific antibiotics for every infection, which can be covered. We are basically trying to cover the principles. So once the team is made aware of the antibiotic policy and how to chart the doses, how to administer the drugs. Now we need to know how to implement the policies of the program and how to check that the program is running well. So this brings us to the antimicrobial stewardship program and what are the implementation strategies. So as we will see with the various strategies which could be followed to know that the proper antibiotic policies are being followed, some of them you'll see are in the front end, so which is prospective, and some are back end, in which they are more of a retrospective feedback. So for example, the best thing to do would be that if you can do it prospectively and in a front end sort of a thing. So especially in situations where you only newly recommending or implementing an antimicrobial stewardship program in a hospital. So for example, you can incorporate the good practices of antimicrobial stewardship during the ward round itself. So for example, in the antimicrobial stewardship committee or the team that has been formed, which also has some clinical experts, you can decide that one day of the week or few days of the week, they will take the rounds of the ward or NICU patients, or they would add to the rounds that the clinician is already taking. And they would decide based on the rounds that if the antibiotics are started or not, whether they are appropriate or not, whether a neonate who deserves antibiotics is not getting it, or somebody who does not need antibiotics is getting it. So what it helps is that it is giving you instant feedback to the team that they have just charted, the patient is still being admitted, still treated, and you can modify and correct the antibiotics. But the issue in our setup sort of thing that a lot of clinicians, a lot of doctors may not like it, for example. So they may feel that in some other team who is not following the patients as much as they are now deciding the treatment, they could see that it's an intrusion on their own autonomy of antibiotics, and it could be time consuming. So the antimicrobial stewardship team, for example, would have other work. They may not be a standalone AMS team itself, so they may not be able to join the rounds. So that becomes an issue. Then the other thing is antibiotic self-revision that can happen. So this is also an evidence-proven way in which you can improve your antibiotic practices. So what this works is that, for example, for every baby or child who has been started on antibiotics, after a set duration, so typically 48 to 72 hours, when your cultures are typically available, the team can self-reassess whether now at 48 hours, do I need to continue antibiotics? Now, do I think that this was sepsis or can I stop it? Other thing is now that if I have a culture positive, can I change it to a lower antibiotic or a narrower spectrum antibiotic? Instead of 2 antibiotics, can I give just 1 antibiotic now? Or if the cultures have come negative, then does it look like sepsis? If it did seem like sepsis, then can I stop antibiotics after 5 days or not? So this is a way in which the clinician can take the decision himself or herself. So there's no third team that is going to tell the clinician that you have to change antibiotics, and a person who has taken the decision himself or herself might be more willing to change it. However, this would not work if the person who is rounding or taking the decisions is themselves not very well versed in the principles of antimicrobial stewardship. So just by attaining a degree or just by being senior does not mean that we know everything. And all of us need to keep learning ourselves about the policies of antimicrobial stewardship. And this holds true for doctors, nurses, as well as, I would say, even grade 4 staff. And you have to teach the parents and the patients also. So a more common example of the thing that can be done often in our setting is the audit with feedback. So how this is done, that you can assess the appropriateness of the prescribed antibiotics can be done by antimicrobial stewardship team. So they do not need to be there at the time of rounds, but they can do that. They can review the files of the babies admitted in the last 7 days, and they can do a sort of appropriate determination survey. So I have attached a photo of, for example, an example of such a form that is followed at AIIMS. So you know the details of the patient, what was the diagnosis, what was the infection diagnosis, and then you can decide when the antibiotics were started, whether it was as per the department policy or not, whether blood culture was sent before antibiotics or not. Now that if the reports have come, has the antibiotics been changed or not? So that the AMS team can appropriately can assess the appropriateness and then later give a feedback to the team that we have reviewed and the antibiotics. So for example, in 60% of the cases, the antibiotics were appropriate. And then this is how you can improve. These are the common problems. So, but it is very important that such a thing has to be constructive and has to be given a specific feedback. So there is no point in being overtly critical or giving a very broad feedback that something is not right, people are not doing right thing. It does not help anybody. So you have to give a specific feedback. So for example, we noticed that the antibiotics started were as per policy, but at 48 hours, the cultures were not changed based on the antibiotic. The antibiotics were not changed based on the cultures. So this is how you can have to give it in a constructive manner so that team can learn gradually. So again, this can be a time consuming because a team has to audit these forms and it may be seen as critical sometimes, but this is sometimes a feasible option in busy setups or in setups where you can the team cannot do a direct rounds with the clinician. So the next policy that we'll discuss is a restriction sort of a policy. So this is a policy that I would say is often effective in the early stages of the program, in which the hospital is just getting accustomed to antimicrobial stewardship and the team is not mature in a sense. So what this means that you have restricted the access to the some antibiotics which are in the reserve category, for example. So to give some antibiotics, there has to be a pre-authorization by a authority or by a leadership. So this is also an example of front end that in which you are trying to change the antibiotic policy before it has already been given. So for example, if you see here, this is the antibiotic formulary authorization policy in the Department of Pediatrics at AIIMS. So for example, if you see colistin, so the authorization can only be done by unit head as well as the HOD. So unless the HOD gives a nod that you can use colistin in this patient, we cannot use it. Similarly, tigecycline, aztreonam or tapenem can be given only by unit heads. Then there are certain antibiotics which are from the access group, for the watch group of WHO category, which can be given by the consultant only. And then there are some antibiotics which can be started by the senior residents only. So this way you ensure that the antibiotics are not used irrationally or in a rash manner by the doctor on call. So the problem is that it could delay therapy sometimes, because you would need to share the summary of the patient with the HOD, who will then have to respond to it. So sometimes the clinicians may feel that it is a very urgent decision and I cannot wait. So there is a possibility of delaying the upgrading the therapy, and then it does decrease the autonomy of clinicians, and they may feel that I do not need to wait for somebody else's approval, and it needs an implementation mechanism. So for example, it has to be known by everybody. So for example, in um, setups where there is a separate pharmacy which gives the antibiotics or disperses the antibiotics, the pharmacist can be made aware that unless he sees a signature from this and this person, he cannot give the antibiotic. But you have to train the pharmacist that he has to withhold those antibiotics. It may not be possible in all settings, so you need to give a mechanism that the guideline of authorization is actually followed and somebody is able to withhold the antibiotics unless they get an authorization from the concerned person. Other useful way is an automatic stop order. So what this means is that, for example, you have started antibiotics for a surgical prophylaxis. Now, in a typically adult patient is recommended to give surgical prophylaxis only for a day. And often you may see that for some surgeries, in neonatal surgeries, you may know that some hernia surgery has been done and the antibiotics have to be given for 3 days. So in those cases, there can be automatic stop that as soon as you have prescribed the antibiotics, you also write that this antibiotic has to be stopped on day 3 after completing 3 days. So this would be difficult in clinical cases in which you're waiting for a culture and you may have to give more days of therapy or lower days of therapy. But in cases where the duration is fixed, like prophylaxis typically, you can give a stop order, and this is typically easier to do in a computerized system. So there are some hospitals which have a totally computerized system of prescribing antibiotics. So in those cases, you can put a stop in which after 3 days, the computer would not allow you to generate a prescription of this antibiotics. So if the system is well developed, and this automatic stop orders is something that takes the load of a clinician later to take a decision whether we have to stop it. And if I don't stop it, it will keep on continuing because it will be automatically be stopped after giving the adequate number of days. So this is how you implement the antibiotic policy decisions and the protocols for the unit. And then, as we discussed, that all these decisions have to be accompanied with ongoing education and training of the staff. And the staff includes all the staff of the NICU or the hospital, because everybody is a shareholder in basically the decision of antibiotics and the fight against antimicrobial resistance. So this includes the basic and the education of clinical staff. It also includes that you should involve the discussions of antimicrobial stewardship in clinical case discussions. So the everyday rounds, you don't have to wait for a special committee or hospital infection control committee to talk to you about that. You can, the consultants who are rounding or the clinicians who are rounding or the senior nurses who are giving the over to a nurse, you can keep the policy, you can make it a habit to discuss the antibiotics, whether this baby requires antibiotics, whether the baby looks much better, what is the day of antibiotic for this baby, can we stop it? So everybody needs to be involved. There has to be regular sharing of information, including through posters, through bulletins, so that because all of us sometimes you realize that because these things are very important and are going in the background, we tend to lose focus of them, and then it just becomes sort of just the wallflower in which you are not focusing it on anymore. So people need continuous reminders that you have to be very vigilant and very, very active in determining the appropriateness of antibiotics. And there can be e-learning resources and unit policies which can be shared with everyone. So like I gave the example of the unit antibiotic policy, which is available as a mobile app. So that really improves the number of people who can access this, so that everybody knows. You don't have to ask somebody, you don't have to go to that place to find that piece of sort of a tech book that will provide you the policy. It is easily accessible to everyone. So as we know that multiple reinforcements improve the uptake of good practices, and this holds true as much as anywhere else in the case of antimicrobial stewardship. The final component of antimicrobial stewardship is the tracking, reporting, and feedback. So one was a continuous feedback that we were talking about, that for this patient, how much antibiotic, what antibiotic should have been given, whether this should have been done or should have been stopped. But one is just to understand and monitor the progress of the whole antimicrobial stewardship program of that hospital or for that unit, how the program is working. So for that, we need to collect certain data, which would be the antibiotic duration, doses. So this are standard indices or metrics that are used to determine the use of antibiotics. Will not go into the details, but for example, some are days of therapy or length of therapy. So how many days the baby received antibiotics, how many antibiotics did the baby receive cumulatively, what was the dose, and then you can have data on these things. For example, the how many babies the culture sample was taken before starting antibiotics, which is a major component of unless you send cultures before antibiotics, you will not get reliable cultures. So you'll not be able to modify or optimize your antibiotic therapy after 48 hours. Then how many neonates received reserve antibiotics, what was the days of therapy, how many neonates in the NICU, especially this is especially true for sick NICUs in which most neonates who are admitted would start on antibiotics. So you can have a reverse sort of a thing in which how many neonates are not receiving antibiotics, so that you can aim that I can increase this number. So this feedback, this data is continuously collected by the AMS team, and this feedback is given to the clinical team and the management so that they can give specific feedback to the team. They can implement mechanisms, they can plan the education, that if this is a common problem that is happening. So for example, a common problem could be that our cultures are growing a lot of contaminant organisms. Then the management will plan that, no, I need to have a refresher training for the staff on how to collect the antibiotic, the culture sample in an aseptic manner, so that contamination is not there. So the without monitorable tracking and reporting and feedback, the program becomes very difficult to monitor that whether it is helping, it is not helping, what can be done, and what specific measures can be implemented. So again, to give an example, in the Department of Pediatrics, this is the antibiotic tracking sheet that we use. So for every patient, there's a list of antibiotics and what infection-related diagnosis is there and how many antibiotics for how many days has they received, so that it can be, the data is then computerized and then it can be later audited that this is the antibiotic policies or practices that are being followed. So this is how the antimicrobial stewardship program is. The core elements, we discussed the principles of the antibiotic therapy, and we also discussed on how to implement the principles in our everyday practice. Now, what is the nurse's role in antimicrobial stewardship? So, as you know, the nurses are the eyes and ears of the entire hospital and the clinical thing. So antibiotics, the nurses are the first responders and the monitors. They observe the babies 24 hours and they would know that the baby is looking better. They would know that the baby was looking lethargic yesterday, but now after 2 days of say antibiotics, the activity looks better, or the activity has improved within say in the morning, baby was appearing sick, but in the afternoon, after starting antibiotics, baby has improved. So this would mean that the antibiotics were not the things, because antibiotics would take some 48 hours or so to improve outcomes. If the nurses can notice that the baby has improved even just with 1 dose of antibiotic, then you have to consider that they need to inform the clinician so that they can consider other diagnosis rather than sepsis, because as we discussed, every sickness is not sepsis. Second, the culture and sample quality. This is a major pillar of how you would tailor the antibiotics once the culture reports are available. So we need to ensure that the volume of blood culture, the technique, in the aseptic technique of culture collection and is proper or not, whether the antibiotics were started only after the cultures are being collected, whether the site-specific cultures are sent or not. So if there is for in other patients, for example, if there is some urinary symptoms, a child is complaining, then the urine samples also have to go. In a child with suppose a ventilator, you may have to send a bronchoalveolar lavage sample. So these things can be ensured by nurses. Even in some units, the nurses may be doing the sampling. In some units, the academic units, the residents may be doing the sampling. But in both cases, the nurses are the ultimate advocates of the babies, and they have to stand there and ensure that the cultures are collected in adequate volume as well as with adequate technique. The third is the antibiotic timeouts that we discussed. So, for example, in some cases, suppose your baby was operated for some routine procedure and some indication, and the antibiotics were started, and now it has been 5 days, and you see that the antibiotics have not been stopped. So now you need to raise the alarm to the clinician, to the doctor, that typically you, from your experience or by the guidelines or by the unit policy, we give antibiotics for 3 days only. It is the fourth day, so we should maybe consider stopping it. Second, now that if 48 hours or 72 hours have happened, you can discuss, you can make a habit that you give it in overs, that the cultures have come, this is the growth that my baby has, and that is why we have changed to this antibiotic. And it's always a good habit to always ask a doctor if they have changed antibiotics, that why have they changed the antibiotics. And this is not just important for the antimicrobial stewardship here, but this is also important for infection prevention and control, because you need to know that this baby of mine has a culture positive sepsis, and therefore the infection can spread from one baby to the other baby. So I have to be extra careful in infection control, hand hygiene. You may have to do some isolation. You may have to do some cohorting of the patients. Then IV to oral transition. So this is often not valid in neonates, but especially in adult patients, after first 2 days or 3 days of IV antibiotics, the patients have improved, the oral intake has improved. You can switch to oral antibiotic. So in that case, there would be lesser IV lines or lesser risk of hospital-acquired infections. But as we discussed in neonatal sepsis, systemic sepsis, most often we have to give IV antibiotics only. Then allergy and adverse effect. So some drugs are known to cause some allergic reaction. So for example, vancomycin can cause a redness or generalized erythema. So again, so it's not just resistance that we are talking about. We discussed that it's the judicial use of antibiotics to minimize the patient harms. So that includes the adverse effect of the antibiotics, the allergies of the antibiotics. So we can take a history of allergy if we know that. So and so again, it's uncommon in neonates, but in older patients, they may be able to tell that I have allergy to this drug, or their previous records may show that they are allergic to some antibiotic. Similarly, there you also do sort of sensitivity testing for some antibiotics. Then you have to be vigilant for reactions or adverse effect. Then patient education, because the nurses are there at the bedside, you are talking to the mothers, you may be talking to the patient for older patients, and you have to be that, take the responsibility that you are part of the team, and it is also your responsibility to educate the patients and their families that they don't need to take over the counter drugs for every fever or every case of viral illness. And once started, they have to complete the course. And then, of course, as we talked, infection prevention uh, uh, has to be a important aspect, and no AMR or antimicrobial stewardship program can be successful without proper infection prevention. So the hand hygiene, the isolation to prevent the spread of multi-drug resistant organisms from one patient to other cannot happen unless the infection prevention practices are up to the mark. So as the leadership or the clinicians or the hospital team, how can we encourage the involvement of nurses? So first of all, we have to train them and keep retraining, the refreshing on the how to obtain sterile cultures, how to interpret the reports, how to decide if the antibiotics are fine or not. Provide the education on antimicrobial stewardship for bedside nurses, and encouraging and identifying the champion nurses who can basically be the go-to person for antimicrobial stewardship for a NICU. So for example, there AIMS has a hospital infection control committee, and there are dedicated infection control nurses who collect the data on, say, central line associated infections or ventilator associated pneumonia, surveillance cultures. So there can be nurses who have dedicated to the infection control. There can the stewardship rounds or the clinician rounds who are discussing antibiotic policies should be accompanied by the nurses managing that baby, and there should be ownership that is promoted to the nurses, and the nurses need to be empowered that they can discuss and they can talk about the rationale justification for the clinical antibiotic decisions. So this is how the nurses can be involved and need to be a major component of antimicrobial stewardship. And so I'll basically just discuss a few best practices or a good clinical practices for overall antibiotic therapy and optimizing the management of infections in a cases. So we don't, again, I want you to just focus on the principle of it and not be bogged down by details. So first of all is vaccinate. So this is again often not true for neonates, but for in any cases, if you can prevent an infection, you don't even have to worry about starting antibiotics, stopping antibiotics, modifying antibiotics. So for the drugs for which vaccination is available, if you can prevent so all the vaccines that we give to children, to neonates, and to adults occasionally would prevent an infection, would prevent the patient from coming to the hospital, and therefore would prevent the antimicrobial resistance from developing. Second thing is remove catheters. So unnecessary catheters are a source of colonization of bacteria, and they can lead to infections. So they have to be kept only if they are necessary. And this includes Foley's catheter. They can include a central line which is there, but the patient is mostly taking orally and central line is not needed. So for example, if 2 days of antibiotic therapy are left, they can be given through peripheral cannula and you don't need a central line. So you remove catheter every day. You decide that whether this baby, this patient requires this Foley's, this endotracheal tube, this central line today or not. Third is the target therapy to the pathogen. So this only happens if you have collected appropriate blood cultures. And as soon as you have the blood culture available, you modify your antibiotics. So when we started with broad spectrum because we wanted to cover 60 to 70% of all organisms, now if we know that this patient has an enterococcus organism, that I can just give this one antibiotic, which should be sufficient for this baby. Then you have to consult a specialist. This means that if there are infections which in settings where the suppose it's a level 2 NICU setting and you are seeing an infection which is not being controlled by your routine first line antibiotics, then if you have a specialist that you can talk to, some senior person, some specialist from infectious diseases, that is always helpful, and we should never be ashamed or afraid of asking for help. The fifth is the practicing correct use of antimicrobials, and this is general, that we understand that we have to be aware of the specific characteristics of the population. What is the dosing? How is the renal status? What is the liver status? And whether this antibiotic is safe enough or not. We have to use local data, as we discussed, that the antibiogram preferably should be as specific as possible, preferably from the same unit. If not, then from the same department. If not, then from the same hospital. If not, then from the same city. And we have to treat the infection and not the contamination. Often when we don't practice asepsis properly, there is growth of some organisms that comes more than 3 gram-positive cocci or some, so for example, Staphylococcus epidermidis organism can grow, and we don't know if it's an infection or a contamination. So we have to be very vigilant that we send cultures properly so that we don't end up treating the contamination. We do not need treatment. And same way, treat the infection and not colonization. So some units have a practice in which once the central line is removed, you send the tip of the central line or tip of the endotracheal tube and so on. But we have to understand that even if there's an organism on the central line, unless the patient is having symptoms, the patient is having blood culture positivity, the colonization of the foreign body alone is not sufficient grounds to start antibiotics. Then we have to know when to say no to vancomycin, cephalosporin, carbapenem, because often to the patient or baby worsening with any illness, our response is to upgrade the antibiotics, which is not the right policy, because it only works if it's an antibiotic. If it's an infection that is susceptible to the antibiotic. A lot of the times there can be other causes. So, for example, a new onset fever can be due to a thrombophlebitis or an inflamed vein due to a faulty cannula rather than a new infection. So here also the role of nurses is paramount, in which if you see a fever, then you can look for a cause of a local fever. There can be thrombophlebitis, there can be some rash, some pustule in neonates. Irritability can be a sign of sepsis, but irritability can be due to a diaper rash also. There can be hyperthermia, which is causing irritability. So there can be a faulty radiant warmer, which can cause cold peripheries and not sepsis. So all these things can only happen if we are actively looking for it. Then you have to be courageous enough to discontinue antimicrobial therapy when it is no longer indicated, and be very strict with following the unit protocol. We have to have all efforts to isolate the pathogen, and the pathogen may not only be there in the blood. Sometimes the pathogen may be there isolated from urine. It can be there in CSF. So in neonates, it is very important to rule out meningitis. Sometimes it can be in the lungs. So you may have to do in a ventilated patient some lavage sample as per the policy. And the most important thing again is to break the chain of transmission. So if you see a sick visitor, do not allow them into the NICU. If they actively have a viral infection, they're coughing incessantly, then you can say that please don't come to the NICU, or if you are coming, please wear a N95 mask, so that they don't end up transmitting the infection to and from your patient. So this was the best practices of antimicrobial stewardship. So let me just summarize the important. I know it has it's almost 70 minutes, so you must be tired, but I'll just summarize the last slide. So first of all, as we discussed, that bacteria are increasingly becoming resistant to most, and if not all available antibiotics. And we have no new antibiotics coming in the near future. Even if they do come, they would not be safe enough to be used in neonates straight away. So you may not get another new antibiotics for 1 decade. So in this case, the two important things that are in our hand is infection control practices and the antimicrobial stewardship. So antimicrobial stewardship simply means giving the right drug to the right patient, to the right dose, right duration, and right route. And again, it is easier said than done, but you have to be very actively thinking and considering that every decision that we have taken is based on good evidence and good reasoning. And the ASP ensures patient safety, the emergence of AMR. So even if you don't see the immediate benefits, as we saw that in the last few decades, how the AMR is likely to cause more and more deaths, and the only option we have is to prevent more resistance from happening. And lastly, no antibiotic policy will help in absence of proper hospital infection control practices. So these are some slides that some further reading material that I based my slides on, and you can, for those who are interested, you can read. The WHO has their own guidelines and a toolkit for making antimicrobial stewardship programs. The US CDC, Center for Disease Control, also has this policy, and the ICMR, Indian Council of Medical Research, also have their guideline on antimicrobial stewardship program, and those who are interested can go through it. Those are 70 to 80 page documents, but not very difficult to read. So just to say this, fever is not a sign of antibiotic deficiency. Thank you. That is all from my side. And I'd be happy to take any questions. And yeah, so I'll just show the slides.
Thank
you, Supriya sir, for taking the session. Sir, you can directly hand over to Dr. Jiva to take on the sessions and add in his few words.
Yeah, I'll just stop sharing. Yes, Jiva sir, I hand over to you to add anything to it and to answer any questions.
No, that's a great lecture, Satya. I think it's simplified and relevant to the particularly the nurses, nursing officers, and industry nurses, and those who are involved in day-to-day patient care. I don't have any slides or I don't have anything else to add. Maybe we can we can just clarify doubts. We can take the questions.
Are you using antibiotic charts, Satya? Antibiotic chart we used to use earlier. I think we have started it here. And also duration therapy and antibiotic utilization rates we are displaying on the board. Either sisters only are displaying it. The percentage of babies who are on antibiotics, I mean AUR kind of thing. So any kind of uh, monitoring or
So, some monitoring for the mostly bloodstream infections and CLABSI are going through our just sepsis discussions, but right now we are not putting the charts that we used to keep earlier in NICU, if you remember that, how many
yes.
are on vancomycin and also that we are not putting anymore. And in fact, we are also facing the brunt of antimicrobial resistance that in the last few years we have seen that much more organisms are becoming resistant and we are having to resort to high-end antibiotics that we did not have to before. So the problem is not just theoretical, and I'm sure all the nurses who are attended and are seeing some reports would know that we often have to use some higher antibiotics, but it cannot be incessant and injudicious use, and we have to have a strong reasoning, is what we need to tell.
Another area where nurses, I think, will be a strong support would be the birthing area and the delivery room, I think, because early onset sepsis, as we all know, it's not only now vertical, but also the care during the time of the birth, the perinatal care, and the interventions which we are doing in the delivery room, like CPAP or delivery room CPAP, positive pressure ventilation. So we do keep on conducting sessions in the delivery room for the labor room staff also. So I think those are also a very important component of, I mean, prevention of infection and actually preventing the antibiotic usage. So that is, I think, one more domain for the nurses where they can contribute. Any questions, Jubilant, or any experience sharing? If
Then, ma'am,
So
no
there's
questions from my side if other
There's one
participants.
question from Raima Cyril. They've said that they want to know if the mobile app was developed by AIMS. So the app that I showed you is basically for the Department of Pediatrics unit policy. It is sort of a controlled app which is only for the internal use, and it is not freely available. And it keeps on updating every year. So the one I showed is from 2 years ago. That was an example. So as I said that. No universal antibiotic policy can exist, and the policy that is developed for one hospital would be based on the antibiogram of that hospital. I hope that is what your question was on.
Satya,
Yes.
hi. So it was a great presentation. I didn't realize you are such a good speaker. ठीक है. I was surprised to find मैंने प्रतिभा से पूछा कौन है भाई ये सत्या इतना अच्छा पढ़ा रहा है. So I realized, and I'm so thanks Jiva. You are mentoring such great people. ठीक है. So सत्या ये जो आपने फॉर्म दिखाया था एम्स का जिसमें सारे एंटीबायोटिक लिखे हुए थे from 1 to top की एक वो पर बच्चे का था. For every
वो हर बच्चे
patient,
के लिए
बच्चे, that's too much of a paperwork again. And for the chartings, other charts also which I found कि जो बच्चे के लिए आप एक एंटीबायोटिक अप्रोप्रिएटनेस डिटर्मिनेशन सर्वे कर रहे हैं, so that is also for per baby who is receiving antibiotic, the antibiotic appropriateness awareness whatever sensitization whatever was doing. So yes,
Yeah.
with the number of volume, if it is the volume of patients are lesser, then it can be done, or the number of staff who are there is good in proportion. So when in most of the SNCUs, when the staff nurses are 5:1, if it is good. In my SNCUs were 20, we have only 2 nurses at time, one nurse. ठीक है, तो it is 10:1 or 20:1 at times also. So you mean to say antibiotic appropriateness हो सकती है कि नहीं हो सकती है?
That's an excellent point, sir. First of all, I thank you for the kind words. So, first I'll take it one by one. So, the principles of antibiotic stewardship would remain the same, and the actual level of implementation would depend from unit to unit and how much resources and time can be dedicated to it. So, but for example, the appropriateness audit that was there, so that does not have to be done for every patient who's on antibiotics, because there may be a lot of patients. But for example, it can be done periodically, that every month there is a committee who, or like some specialists who are sitting and seeing the antibiotics that are currently ongoing and whether they're appropriate or not.
So I
So
took a snapshot of yours. I took a snapshot and send it to my department that we will do it monthly, one kind of a or random sample of this. I hope that
yeah,
has been done at some places also, because replicating the one which you have said seems absolutely impossible to us.
Yeah, I understand that. The tracking sheet, I feel, is not does not add too much of a work, and I am sure Sis Jubilant can add to it. But so it is already attached to the nursing sheet of every patient. So all it needs is that one patient would typically receive maximum 2 antibiotics, 4 antibiotics, and for those they would just, for the given date, they would put on putting a tick or putting a dot mark. So the data collection is at the time, if you do it right at the time that they're transcribing an antibiotic into their nursing sheet, they can just put a dot that today this antibiotic has been given. So if it is done retrospectively, the antibiotic tracking sheet that I showed, it would be difficult. You have to open the file, but it is done prospectively by the nurses. So that antibiotic tracking sheet is part of the nursing sheet itself. What
That
do you
would
think?
require the number of nurses. That would require the number of nurses.
That
Yeah.
would absolutely do. So I understand your point, sir. And uh, so like you're saying that the nursing to patient ratio maybe 1:10 or occasionally 1:20. And so then you have to pick and choose of which policies can you implement and which you cannot do. So
Yeah.
for example, I mentioned about the electronic automatic stops or something. Those things even we do not have right now. And maybe
Yes.
they're only in some Western setups.
Yeah.
So the point is to just be better than what we were doing yesterday.
What
And
you
so
have
that
best. Yeah, sure,
at
sure.
least the antibiotic policies, cultures can be sent. So if that can be implemented, or we can make a habit that every third day of starting antibiotics, it is a policy that as soon as you see day 3 of antibiotics, there has to be automatic alarm in your mind that no, now I have to trace the culture and I have to decide the antibiotics if the culture facility is available again.
Antibiotic huddle in the morning or somewhere, if
Yes,
that
that
is.
is also an excellent idea, and that actually helps in sort of maintaining the
Because
motivation.
Dr. Shushma Nangia used to tell in from Lalish, I don't know, Pratibha, that the antibiotic percentage in the unit being
Yeah,
displayed.
that is what I was saying, sir. We have a whiteboard and we do display, and nurses only calculate that and write it. They just take a cross section of the babies who are there at 9 a.m. in the NICU. Suppose 30 babies are there, and how many of them are receiving any antibiotic. So that percentage is displayed, and that is done by the sisters, nurses only. And that gives a visual impression of how we are doing daily. So, as
I
Satya
think
said,
this is, if to begin with, this can be a good things to do so. Though it may be very not, it will not give the kind of antibiotics, the pre-authorization antibiotics which you were mentioning, the higher level of antibiotics, but
yeah,
certainly it
to
will be a
begin with,
big
that can be done. So
good.
that we just know that कि 15% से अब 40% babies आ गए
Yeah.
हैं on
Yep.
antibiotic. So that can give an idea. Then we can go into the details perhaps. So that's antibiotic tracking sheet that we also are planning to incorporate in the nurses monitoring chart. QI की तरह ही है sir. Load है,
Uh,
but then ultimately it will help in long
I
term. तो
think
help करेगा unit में. तो that is can
I
be
will
incorporated.
take Satya's inputs more and more. Anyone else? Because there are so many. मैं अंजलि भी देख रहा हूँ, मैं अनुग्रह चारण है from
हाँ, अनुग्रह भी है,
Lucknow.
अनम्यूट करके बात कर सकते हैं if you want to share anything or if you think what can be done or what how can you contribute. Bhavna, you want to share something from Safdarjung Hospital?
भावना अनम्यूट कर सकते हैं.
Yes, sir. Am I audible, sir? There is some.
Yes, yes, you are audible.
Okay, sir. So, very well, very nicely session taken by Dr. Satya, sir. First of all, and there is one question in the chat board that what about DOT and DDD by Sujita
Yes.
ma'am.
Yeah.
So,
So there are some, as I mentioned, that there are certain indices that are recommended by the CDC and WHO, which are standard metrics, like the matrices which can help us to track the progress of the antimicrobial use. So one of them is days of therapy. So what days of therapy would mean that for total how many days did the baby receive one or more antibiotics. So for example, if the baby received piperacillin tazobactam for 2 days, and after that the baby was shifted to meropenem for 5 days, so that and amikacin has been going on throughout, so the baby received antibiotics for total 7 days, 2 days plus 5 days. So the days of therapy uh, would be basically added for the different drugs. So for example, 2 days of piperacillin, 5 days of meropenem, and side by side 7 days of amikacin went. So the days of therapy becomes 2 plus 5 plus 7. So that becomes 14 days of therapy. The other thing is length of therapy. So the length of therapy is a different term in which basically, irrespective of the number of drugs, how many days did the baby receive the drugs. So in this case, for example, the baby was started on amikacin, received for 7 days, 2 days of piptas, 5 days of miro, but total 7 days baby received one or more antibiotics. So the length of therapy becomes 7 days. Then there is a defined daily dose, which is again a term used by WHO in which the average daily maintenance dose of an antimicrobial is used. So these are typically described for adult patients that so for example, they have said that for azithromycin, 1 gram per day is the standard dose. And if the patient received 500 mg, then it would be 0.5 unit of defined daily dose is what the patient received. This is difficult to follow in neonates because the doses may not be extrapolated from the standard adult doses, so often not followed, but days of therapy and length of therapy could still be followed and could be a standard matrix so which you can compare your data, your antibiotic use with other units, for example, and even from your own unit in the past. Jeeva sir, would you like to add anything to it? I thought it would be too technical and I did not cover this.
Yeah. So the DDD definitely is not for, it would be almost impractical to use in NICUs. Day of therapy, that is possibly easier to use, but I think we should always start slow, and then we should start something which is simple. Maybe the easiest way is, for example, proportion of babies on reserve drugs, for example, meropenem. Or first, you can start with at least proportion of number of babies who are on polymyxin B or cholesterol, for example. Then meropenem, vancomycin. So at least 3 drugs. That is more. So if 80% of the babies are on vancomycin or meropenem, then that indicates something is wrong. So you can start something like that and then go to a complex thing like the day of therapy, or and then go to something else. Unless you're going to report or you're going to publish these standard definitions, and use of these standard definitions might not be that. I would say it will not be useful. I won't saying that it'll be like worth the time, particularly when that Bistro highlighted many units in which nurses are not actually enough to handle the patient load. Anything that is additional is not going to be sustainable. So that's important. So you start something that has to be sustainable. So think simple starts with very simple things, simple metrics that can be easily measured and that can be acted upon. I think that's more important.
Thank you.
thank you, Dr. Jeeva sir. So then there is no more question, I think, in the chat box. and now we can conclude. So before concluding the session, as always, I would like to convey my key 5 messages to you all, that antimicrobial stewardship is essentially NICU to ensure rational antibiotic use and to prevent the growing problem of antimicrobial resistance, as already very well session taken by Dr. Satya sir also. Regular infection surveillance helps in early identification of infection trends, as well as strict adherence to infection prevention practices like hand hygiene, aseptic techniques remains the cornerstone of safe neonatal care, as it is also recommended by WHO. And finally, judicious selection, dosing, and duration of antibiotics are crucial to ensure effective treatment. And a multidisciplinary team, that is by including all the neonatologists and infection control team also, that is very important in strengthening the antimicrobial stewardship programs in NICU. So I would like to express my sincere gratitude to our esteemed speaker, Dr. Jiva Shankar sir and Dr. Satya Prakash, for their meaningful insightful presentation and valuable guidance on the important topic. And I would also like to extend my heartfelt thanks to our respected moderator, Dr. Pratima ma'am and Dr. Surinder sir, also for her expert moderation and valuable inputs during today's session. Finally, I thank all the participants for their active participation and interest. With this, we conclude today's session. Thank you, everyone.
Thank you.
Thank you,
I
everyone.
will take this opportunity to thank both of the speakers for today's session. Thank you, Dr. Satya, for
But Jubilant is
orchestrating
still on
and
duty. Jubilant is still on duty. My God.
Yes.
Double काम करा रहे हैं उससे. Okay. All the best.
Thank you, Dr. Satya, for orchestrating and presenting the presentation so well on antimicrobial resistance. And thank you so much, Dr. Jiva. And it is a very well enriching experience to learn from you, who is the stalwart for this antimicrobial stewardship program in AIMS as well as the whole India, I would say. So thank you for both of your presence and always your keen guidance for the same. And I would take this opportunity to thank Dr. Pratima for moderating the session so well. And I would just add in few points, like it is very well noted that the judicial and empirical use of the antimicrobial in any unit, whether it be ICU or any ward, it is like very judicial, and it should be utilized very judicially for the enhancement of achieving the patient result or the desired effect of the patient, rather than imputing any further harm for the patient. And also, I would like to say that the empirical team that is developed during this session, that is the interdisciplinary teams and the multi-level hierarchy that is approached and utilized for the antimicrobial stewardship, is very important, that we got to know in this session. And we will be utilizing all these stipulated protocols and stipulated principles that we have just studied in each of our units. We will utilize them. And also, to add in the point for which Dr. Surendra Singh just asked, for which, for me, as per se, we do not feel it as a burden, the particular usage of the antimicrobial sheet for each of the patients. Because as Dr. Satya just briefly explained, that we just add in the name of the patient and the related details such as UHID and what is the current diagnosis and date of admission of the patient, followed by the current usage of the antimicrobial. So for that, we just put in a dot for whatever antimicrobial therapy the baby is ongoing with. So it doesn't seem a bit of an exertion from our side, but I understand that since in SNCUs the patient load is much more higher for any given nurse, so it can take a hit back for the same idea. So we can utilize the very idea of which is being incorporated in LHMC, for which Dr. Pratima eagerly told. So that were my few of my points, and thank you. So we will conclude this session. Good night, everybody.
Thank you. Thank you, Jubilant. Thank